have 2 minutes for any contributions or questions that you would have. So when you are writing your questions, let them be very short because we have only 2 minutes to ask and answer. Thank you all very much. All right, so we have the first person to present to us as Madam Alice Opon Damprani. She's an emergency nurse fellow. Specialist or fellow? All right, fellow, and then fellow in information. All right, very hard-working emergency nurse in Konfanoche Teaching Hospital. If for anything at all you get to Konfanoche to do emergency medicine, try and look for her and work with her at Red. Your shift will be very comfortable for you because I've worked with her before. All right. She has a long list of bio that we should read, but for time's sake, we'll call her to do her presentation. Madam Alice, she's presenting on knowledge and practice of cardiopulmonary resuscitation among nurses in the emergency department of a tertiary hospital in Ghana. So, Madam Alice, you have your audience. Thank you.
Good afternoon. Thank you very much. You are welcome from your lunch break. I have 8 minutes, so this work was done at the Accident and Emergency Department of Konfanoche Teaching Hospital. So as you rightly said, knowledge and practice of adult cardiopulmonary resuscitation among nurses in the emergency department of a tertiary hospital in Ghana. So this is the outline. We talk a little about the background, the methods used, the results, the discussion, conclusion, and then the references. So we all know we do cardiopulmonary resuscitation when there is a cardiac arrest. So what is cardiac arrest? When there is, we all know cardiac arrest is a medical emergency, and then it's characterized by an abrupt cessation of blood flow, and then you see that it's evidence of loss of palpable pulses and even loss of spontaneous respiration. And then when I did the research, I saw that cardiac arrest is a substantial public health problem, which is estimated to account for 15 to 20% of all deaths worldwide. Cardiopulmonary resuscitation is a resuscitative medical procedure that restores normal spontaneous blood circulation and breathing in a person who is in cardiac arrest. Although it's reversible, prompt attention is needed. The time that you start your resuscitation is very important to help in the survival of your patient. So cardiopulmonary resuscitation, we say, is a core emergency skill, and as such, every health professional should know how to do the cardiopulmonary, so both BLS and then the ACLS protocols. Nurses working in the hospital emergency department can reduce mortality resulting from cardiac arrest and respiratory-related problems when they are equipped with knowledge and skills in cardiopulmonary resuscitation. This is so because we know that nurses and their proximity with our patients, we are the first people to see that patient is in cardiac arrest. And as such, if we have the knowledge and skill, we'll be able to initiate the CPR response and then call for help. So hence the need for this study. We saw that when we started the emergency department, we were enthused. When we say code, everybody will be running there. But of late, people are getting tired. And some will be saying that even if you do it, this patient will not survive. But when we go to the questions and the questionnaire, we know that most nurses answer that there is revival. And so after this presentation, please, when we call you that there is a code, don't sit down, run, and then let's help save the patient. And I also realized that there is paucity of information concerning CPR among nurses at Konfanoche Teaching Hospital, hence the need for this study. So what was the main aim for this research? This study assessed the knowledge and practice of adult CPR among nurses at the emergency department of the Konfanoche Teaching Hospital. So that's our study setting. And then the research approach was a quantitative method. And then the design used was a descriptive cross-sectional study. And then 132 registered nurses were randomly selected and interviewed in the emergency unit of CAT. A simple random sampling technique was used in recruiting respondents for the study. So we didn't want any bias. So we had to give every nurse an equal chance. So a simple random technique was used. All the 132 participants were approached to participate in the study after giving their consent. So now, this was the demographics. So when we come here, we saw that the females were more than the males at the ED. So male represented 31.06%, and then females 68.94%. The age group, we saw that between 31 and 40 years represented 62.88 at the ED, followed by those between the ages of 20 to 30 years. Then with the level of education, we saw that most of the nurses had degree in nursing, representing 50.76%. And then with those with postgraduate degree represented 11%, and then those with diploma in nursing represented 36.36%. Which means that we have nurses who are really knowledgeable. And then if they are able to train with the BLS and the ACLS, you can get good results. So we did some questionnaire on the knowledge level of the nurses. How was this knowledge scored? So we had 9 questions. So it was categorized that all those who scored below 4 were not knowledgeable, and all those who were able to score 5 and above were knowledgeable. So questions like the goal of CPR was asked. And then some of the answers were to maintain respiration, but most of them were able to answer that CPR is done to help maintain blood flow to the brain and other vital organs. So we had 65.91% of nurses getting this answer correct. And then we asked the question of the correct sequence of BLS. We all know it used to be ABC, airway, breathing, circulation. So before you even start your chest compression, but with the American Heart Association guidelines in 2010, it was changed to CAB. So when you see that someone has coded, you need to start your chest compressions. So then again, the nurses that answered these questions, we had 65.91%, representing 87 nurses who got this answer correct. And then the maneuver used to open airway during CPR in a patient without trauma, most of them were able to get the answer. 97 out of the 32 used the word head tilt and chin lift. So they got it correct. And then how long should a pulse check be done? And then most of them were able to get it to no more than 10 seconds. All right, so we move on to the rate of chest compression. All these are the questions on the knowledge of the CPR. So most of them were able to get the answer that is 100 to 120, representing 59.09%. And then the correct depth of compression of adult patient CPR, 37.88%, representing 50 of the 132 nurses got it correct. With the universal ratio of chest compression to ventilation, we know that for adults it's 30:2. And then we had 112 nurses from the 132, representing 84.85, getting these answers correct. And then also the components of CPR. The questions that were asked were allowing full chest recoil, which is correct, avoiding excessive ventilation, minimizing interruptions. So the answer they were to choose was all of the above. And then again, we had 64.39% of nurses doing it. So I was asking myself, were they getting tired? Because we thought they had no knowledge. Okay. So we go to the use of the defibrillator. What at all is the defibrillator used for? Is it used to deliver therapeutic shock to the patient or what? Yes, and they were able to. Now, a little question on our practices at the ED. Have you ever performed? They were able to answer, because for Confanochi ED, every day, if not every day, maybe even 3 times a week, you might get someone coding and then you do CPR. So all people were able to answer that. For the past years, they've been doing the chest compressions. And then, do you feel confident to initiate CPR? 125 out of the 132 were confident in initiating that. And then also, is CPR within the scope of nursing practice? Then the question comes to, should we add BLS to our nursing training syllabus? Because it's not there. So I'm entreating my Mr. President of EMSOG to help us come up with certain so that it can be inculcated in the nursing training course. Have you used a defibrillator for, we all know that for the defibrillator, normally it's the head of the team that uses it. So most of the nurses have not used it before, even though they've witnessed it being used. Have you ever been successful at, this is the most important thing, in resuscitating a patient in a cardiac arrest? We had 116 out of the 132, representing 87.88%, stating yes. So the question is why? When we call code, you are there. You don't want to go and then do it. Why? Because people are surviving, according to this research. So please, let's go back and do our work well. So these are some of the discussions that we came about. So the study found more than 2/3 of the participants knew about the change of the previous airway breathing circulation of basic life support algorithm to circulation, airway, and then breathing, which is documented in the 2010 American Heart Association guideline, which I stated earlier. And the study also revealed a good level of knowledge of CPR because we had to test getting all the answers correct. And then this finding supports what was found in some cross-sectional studies conducted in a tertiary hospital in Nigeria, where nurses also had good knowledge of CPR. ED nurses tend to perform better on CPR practice, and this may be as a result of regular involvement in resuscitation. So whilst we are practicing, when we call code, you are there, will also increase. And then also continuous training will help you have the good knowledge. And then we also found out that in this study, less than 50% of nurses indicated some barriers. So in as much as the practices are good, we also found out some barriers to CPR. Due to the unavailability of protocols, resuscitation teams, appropriate equipment and medicines or adequate staff. So unavailability of equipment, I won't waste much time, you all know. At times, there will be code, you are running a laryngoscope. The doctor will get it and the light is not coming. A CPR with the team lead to coordinate and manage CPR incidents and explicitly distribute tasks among team members has been found to improve the quality of CPR. So I always see our attendance on our emergency doctors. Once there is code, assign roles. Assign roles. Let's have a team leader, because it's been documented that when we have a good team leader with assigned roles, we have a good outcome. Furthermore, the success of CPR has also been found to be negatively influenced by unavailable or poor quality equipment required, as I've stated earlier. So now let's look at some of the limitations of the work. We saw that this is a single-center study and we cannot generalize it. So this is a study for Konfanochi Teaching Hospital, and then it cannot be generalized to UGMC or Kolebu. Maybe they have a different thing there. And then also we saw the high turnover of ED nurses. When you go to Konfanochi, most of our experienced nurses have traveled. So always the new nurses are coming in. And then you have to start again. So these are some of the limitations. And then some recall biases, because this study was asking them questions of things that had happened earlier. So some might even forget to do so. These were some of the limitations. In conclusion, knowledge level and practice of CPR was high in this study for ED nurses. A few challenges, such as the unavailability of protocols and guidelines and lack of resuscitation teams and appropriate drugs and equipment, were reported as barriers to quality CPR. We've also realized that effectively training and retraining nurses will help. So these were my team members who supported me. Thank you very much.
All right, Madam Alice, thank you very much. So we know CPR is very important in our daily life. Not only in the emergency room, it could even be outside the emergency as well. So we have just 1 minute for any contributions or questions. Yes. Any other microphone?
Were you able to, since you have a good number, and you took the ages of the respondents, were you able to establish any connection between probably their ages and their hesitation in participating in the CPR or something, or probably their years of experience? Was there any association between that?
Oh, okay. So thank you very much. So it's something I want to build on. So this is the first step. So probably in the next one that I want to build on this knowledge, I can compare the ages to their practices. So this one, we didn't look at that. Thank you. So thank you very much.
Thank you. Okay, so thank you very much. Other people are coming. So now that you are listening, a team member should listen. Okay, so we thank Madam Alice so much. No, it's not this. So we do this one. So with this one, we do this. All right, so we realized that 8 minutes was not enough. So we gave her 10. She even went a bit overboard. For all presenters, know that this is being scored, okay? So that's what Dr. Owu and I are doing here. So try to keep to the time so that it doesn't affect you. All right, but that doesn't mean you shouldn't present your work well. Present it and then let's move forward. Okay, thank you very much. So our next, no, it's going to be this one. Mami Ebua. All right, so our next presenter would introduce herself to us, but she's one of our very hard-working residents at the Kolebu UGMC hospitals in Accra. You know, in Accra, we have the 2 facilities offering the emergency medicine program, and then we run the program in both hospitals. They spend 6 months in one hospital and 6 months in the other. So we don't know if who belongs to Kolebu, who belongs to UGMC. All is that they belong to the Accra team. All right, so she's coming to present on cardiac tamponade in the emergency department, diagnostic and therapeutic ability of point-of-care ultrasound. So, Dr. Mami Ebua, if there's anything else I've not added to the introduction, you can add it to it. Okay, she's smiling at me. She has accepted the brief one I've done. So thank you very much.
Thank you, Dr. Abuli. Good afternoon once again. My name, as has been mentioned, is Mami Ayeboa. I'm a third-year emergency medicine resident in Kolebu Teaching Hospital. This is a case presentation with a focus on the use of point-of-care ultrasound in the emergency department. And this patient was seen by myself and a couple of colleagues of mine, Dr. Anis and Dr. Latifa Gistal, who is our chief resident, and some of our junior colleagues. Dr. Kwa also was a supervisor for this paper being written. And the patient was seen in the Kolebu Teaching Hospital earlier this year, and the paper was written this year as well. Cardiac tamponade, as we know, is a life-threatening emergency, which is caused by fluid being accumulated in the pericardial space. And the pathophysiology is that of reduced cardiac output, which is not always related to the volume of the fluid in the pericardial sac, but the pressures that the fluid exerts on the right ventricle particularly. In our literature, we are taught that there are three classic symptoms: hypotension, JV distension, and muffled heart sounds. But in the emergency department, these things are very difficult to pick up, especially when the patient is acutely breathless or very critically ill. So it is important that we know how to pick up cardiac tamponade very early and manage the patients appropriately so that we do not have adverse complications, one of which is death. That is where point-of-care ultrasound comes in. Because of its easy accessibility and ease of use, it is able to help us, one, identify cardiac tamponade and aid us in draining the fluid and giving the patient the needed treatment. So this particular case highlights the importance of point-of-care ultrasound in rapidly diagnosing a patient with cardiac tamponade in a low-research setting like ours and in a lot of our training centers. The patient was a 53-year-old female who presented to our ED with progressive dyspnea. She had been dyspneic for 3 weeks, which was progressively getting worse. When she came in, she was in bad respiratory distress. Respiratory rate was 32 cycles per minute, saturation at 88% on room air, and she had cool extremities. At the time, it was difficult to tell exactly what was wrong with her. We went through the primary survey, we did interventions. One of our interventions was putting her on a non-rebreather mask, which improved her saturation to 96%. However, she was still very acutely dyspneic. Therefore, that was changed to non-invasive ventilation later on. These are the vitals. She came in with a BP of 136, 111 millimeters of mercury and a heart rate of 117 beats per minute. She was alert. She did not have any neurological deficits, and temperature was 37.8. As I mentioned, we put her on CPAP with an FiO2 of 98% and a PEEP of 6. The reason why we initiated this is because even though she was being oxygenated, she was struggling with her ventilation. At the time, we weren't sure whether it was a cardiac or a pulmonary condition, so the CPAP was just buying us time while we made the diagnosis. Then we secured IV access, we put her on a cardiac monitor, and then we took the relevant investigations. Then our initial diagnosis was acute respiratory distress from a pulmonary embolism, from pneumonia, from pericarditis, or acute coronary syndrome. We also considered a pneumothorax. So we did an ECG which showed sinus tachycardia, low voltage QRS complexes. I'll show the pictures at the back. Okay, let me just show. Yes, so this is her ECG, which showed the sinus tachycardia. She had a heart rate of 115 beats per minute. It also showed that the QRS complexes were all low voltage, which suggests pericardial effusion. She had electrical alternance as well. She had random ST segment changes across the lateral leads and inferior leads as well. These were the points of care images. This image was captured using the butterfly ultrasound probe, which is very readily accessible, very easy to use, and attaches to every machine that has iOS and has the app. So an iPad, an iPhone, you can connect it to the probe, which is what we used for this patient. So we see on the right, it's a picture of the parasternal long axis view showing the pericardial fluid and the pericardial fluid, the right ventricle, left ventricle labeled LV, and then left atrium labeled LA. Down there is the descending aorta. So this is a video showing the parasternal long axis view of the patient in real time. You can see how the right ventricle is, we call it the trampoline sign, the right ventricle free wall is collapsing with every beat. Then this is in the 4-chamber apical view, showing the same chambers, and then this is a video showing it in real time. We can once again see the right ventricle collapsing as well. So after obtaining verbal consent from her, we did a pericardiocentesis under point of care ultrasound guidance via the subxiphoid approach. A total of 150 ml of serosanguinous fluid was drained, and immediately she improved clinically. She went off the non-invasive ventilation, went off the oxygen, and she was not in bad distress anymore. We put in a drain for continuous drainage, and then we took some of the samples to the lab for further testing, because at the time it was not exactly apparent why she had the pericardial effusion. Okay. Unfortunately, we were unable to capture an image or a video of the actual patient's pericardiocentesis via the point of care ultrasound, but this was another patient, totally different day, that also had pericardial effusion that we drained. The hyperechoic thing going towards the apex of the heart is the needle going under ultrasound guidance to drain the fluid, which is the large hypoechoic area around the heart. Now, why is this case clinically relevant? It just goes to show us how important point of care ultrasound has become in places like our emergency department, where access to high-end or high-level investigation is a bit limited. But with the help of the point of care ultrasound, you are not only able to make diagnosis, but you are also able to offer therapeutic drainage in the case of this patient who had a pericardial effusion. In cases where there was another case report in our ED where point of care ultrasound helped us to make a diagnosis of pulmonary embolism and eventually thrombolize the patient who achieved good progress clinically. So point of care ultrasound is portable, accessible, and this is very accurate because you are seeing the things in real time. And why this is important is because it is necessary for us to be able to understand the importance of it so that we can push for its integration into routine emergency care. Train people in it routinely, train medical students, train residents in all disciplines in point of care ultrasound so that wherever anybody is and there's an ultrasound, they'll be able to use it to do the good work that needs to be done. A case in point is the emergency medicine residency, where points of care ultrasound is the core part of our training. And because of how often we use it and how many times we get trained on it, we are able to use it to make prompt diagnosis and treat critically ill patients in real time, in no time at all. And because it has worked in our departments, it's very, very likely that it will work in other departments. When people come into our emergencies from other departments, like in surgery and other places, we are able to expose them to points of care ultrasound because it looks like it is only in our department that we use it regularly. But exposing other people to it, you realize that in their departments, they can also find use for the points of care ultrasound and to make their work and their lives a bit easier. We are also advocating for it to be taught to people in primary healthcare areas, in polyclinics and in other peripheral facilities, so that before the patient gets to us, if there's any intervention that they can use it to do, they will be able to do it. And it's not a difficult thing to teach. It's not a difficult thing to have, yes. So with the handheld devices and everything, you can connect it to whatever iOS device is available to you and be able to use it to make diagnosis and treat your patients appropriately. These are the references for the abstract. Thank you very much for your attention.
Thank you very much, Dr. Yeboah. Really, you kept to the time, and we are grateful. Please, any contributions, questions?
I want to ask her a question because she was disturbing me yesterday. My name is Ofori Bwedu. 13 years ago, myself and Dr. Nyame had a similar case. I wanted to find out what was the underlying cause of the pericardial effusion.
Yes, please. I did not cover that because of the time constraint, but the patient eventually had further testing which showed that she had what looked like a rheumatology condition, because aside the pericardial effusion, she also had bilateral pleural effusions, she also had fluid in her abdomen, and she had other signs that pointed to a rheumatologic condition. So she was further followed up by the internal medicine team.
Okay. Because the commonest cause is TB in Ghana.
Yes, please. So she had testing for that, but it was negative.
Okay. So I think there's something that is very important. We should know all this. I just had experience. When I was talking to another fear that 13 years ago, myself and Yamidi, we only had pictures. We couldn't make any publication because our thinking was save life. And I had the pictures on my phone. It's very good we are telling us this. But the commonest cause we know in our primary care is TB. 95% of people who come with pericardial effusion, almost 95% have pulmonary TB. And so that was what we learned, and we started picking them up. So I'm grateful for the presentation.
Thank you very much.
Okay, so there's a hand. Okay.
Thank you for the nice presentation. It was really educative. I just want to find out how the 150 mils were drawn out. I mean, was it at once or it was staggered? And the procedure that was used to draw them out?
Dr. Sekwam, was it at once or it was staggered? It was we put in a drain, so it was continuous drainage, but we noticed that after we drained 150 mils, then she improved. But we left the drain in for continuous drainage because it was a large effusion. Yes, please.
So why did you? Oh.
Thank you very much. My name is Jabil, and thank you for your presentation. I would like to know the point of
Care ultrasound. Yes.
point of care ultrasound scan device. Is it readily available, and whether other facilities can even afford? Because I see it, if not Cath and maybe AGA hospital, I've not seen it in any other hospitals.
Yes. So readily available, as in you can walk to a shop in Ghana and buy it. No, but it is something that you can access. When I was in the district as a house officer, the facility I was in had one, because they connected with partners that were able to get them one. So you can get it, but not like it's not as readily accessible as yes.
Really, the other part of your question is beyond her. As to whether it's affordable, that one.
The affordable.
All right, so point of care ultrasound devices are readily available. The question sometimes is its affordability. But what she described is the butterfly. The butterfly is a bit more expensive, but extremely high quality. And of course comes with a software that you can use for other things. They keep getting cheaper because they are miniaturized. Every facility should actually have a point of care ultrasound, because as she described, its use is not just for what she just described. There are a lot of other things you can use it for now in the acutely ill patient. It is not as expensive as a portable X-ray or a CT scan, but now there are a lot of things that we don't need to move a patient to CT scan. More so for a patient who is unstable, you cannot move the patient. A number of our residents have handheld point of care ultrasound. So that means that it is affordable. No, I'm serious. Because yes, we buy cars, don't we? We buy other things. It is priority. And with training sometimes comes with discounted prices of some of those. So the one thing I want to say to acute care practitioners is, one of our difficulties sometimes we don't want to invest in our own skills. You would be surprised to have an orthopedic surgeon who has not bought most of what he uses to do his locum. And some of those may be more expensive than the car he drives. But his locum will be forever. When it is critical care, emergency medicine, $2,000 becomes too much money. $2,000 becomes too much money for us. But the point I want to make is that they becomes more affordable and more worth it. The trainings will run plenty. There are a few more coming. We are talking to some people to see whether we can get more discounts. Almost half of my residents have their own ultrasound.
All right, so thank you all very much. We pray that one day having an ultrasound by a doctor will be like having a stethoscope. Yes. All right, and then I want to challenge us as emergency physicians. I mean, the books really say what Dr. Foriboedu said, that most of pericardial collections in our part of the world, it's TB. But I want to challenge the emergency physicians to refute that one day. Because I've done a lot in the emergency. I can't remember even if up to 2 of them were TB. So the books, the records say so because that's what people have researched on. But as emergency physician, the problem we have is that we don't keep data. Because I doubt even if you have data on this patient and other patients that we've done these procedures for, so that one day we can bring out our data to convince the Western world that TB is no longer a problem for us. So thank you very much. All right, so we are going to have the next presentation also by the Accra group. Now, we no longer have UGMC, Ridge, or Kolebu. It's Accra group. All right, and these are very hard-working residents. If you pay them a visit one day, you like to do residency in Accra. Yeah. let me just give you one of the secrets. I envy them because when we were doing our residency in Confanoche, we didn't have a lecture day. So you could do your night, and the next morning you go and sit and have a lecture. You'll be dozing off, you still have it. They have a lecture day dedicated to lecture only. And their lecture days, the reason why I don't envy them is that they do a lot of research work reading before they go, because they have to write a test before they do their own presentation. We have cooperation from even outside, let me say outside Accra, because both our colleagues in Confanoche and those outside Ghana all help us to do the training. So please come to Accra for your training. All right, so we have Dr. Ida, one of our hardworking Accra residents, coming to present on. And this particular topic is part of the pre-conferences for the Ghana College graduation this year, which is on animal bite. The emergency department is doing animal bites, and we are basing more on rabies and then snake bites. Okay, so read well and come and ask us questions or support us that day. All right, so she's presenting on a preventable tragedy, fatal human rabies after a domestic cat bite in Ghana. So Dr. Adai, please. We are all ears.
Good evening, everyone. My name is Ida Masli, second year emergency medicine resident. And we'll be speaking to you about a case of fatal rabies encephalitis following a pet cat bite in Ghana that we saw in our ED about 2 months ago. So rabies is a fatal viral encephalomyelitis, which is transmitted from the Lissa virus. The incubation period is 2 weeks to 3 months typically, but depending on the site of the bite and then the viral load of the animal that bit you, the incubation period could be as little as 1 week or as long as 1 year. In Ghana, there was a research done by PK Texan on rabies for the cases that were documented from 2010 to 2017. And in those 7 years, Ghana had 328 rabies cases. 91.2% of that was from dog bites, but 12 cases representing 3%, 3.17%, were from cat bites. Which is a statistically significant number. Usually, non-canine bites are missed for post-exposure prophylaxis because, as clinicians, we assume that it's only a dog bite that can give you rabies. And that's what happened with this patient. So she was a 54-year-old woman who presented to our ED with a 48-hour history of hydrophobia, intermittent agitation, hyperventilation, and persistently high blood pressures. So 3 months prior to presentation, she had been bitten by her pet cat on her right foot. It was a deep bite, but when she went to the peripheral facility, the wound was washed and dressed. She was given tetanus prophylaxis, but no rabies post-exposure prophylaxis was given. About 48 hours prior to presentation to our ED, she developed refusal to drink, dyspnea, and then persistently elevated BPs, for which she was sent to the referral facility and then referred to the University of Ghana Medical Center, ED. On presentation, her blood pressure was 270 on 120 millimeters of mercury with a heart rate of 68, respiratory rate of 24, and a temperature of 36.6. She had pronounced aerophobia and pharyngeal spasms with persistent severe hypertension despite IV labetalol. So she went through the labetalol protocol, had received about 4 doses, BPs were not budging. So a diagnosis of clinical rabies was made on account of the history of the cat bites and her clinical presentation. Unfortunately, we know that once the diagnosis of rabies has been made, no antiviral treatment would be effective in curing the rabies. So she was given supportive care for the 27 hours that she was with us until she unfortunately passed. After she passed, public health was contacted and they followed up on her relatives and realized that 3 of her children had also been bitten by the same cat. However, they were not exhibiting any symptoms at the time, so they were then given post-exposure prophylaxis together with her husband. And then the veterinary teams launched vaccination campaigns in the neighborhood where the woman lived. Where's the cat? Very important. So the cat was put down by the vet team. So for our discussion, this woman came to us with a history of a bite from 3 months ago, which is consistent with global data for the incubation of rabies, as we know, which is 2 weeks to 3 months. Now, the virus, once it enters the body, travels peripherally via the nerves into the CNS, which would cause an encephalitis. And once you get to that point, it's fatal. There's nothing we can do about it. Hydrophobia is pathognomonic for rabies. So once you have a patient that comes to you with hydrophobia, you should think about rabies. What is hydrophobia in this context? It's the paroxysmal pharyngeal spasms on attempting to drink water or any liquid. So if you have a patient who has paroxysmal pharyngeal spasms when you attempt to give them something to drink, then you should be thinking rabies. The autonomic storms that come with rabies is what would cause your severe persistent hypertension and your tachypnea, and rapid deterioration, as was seen in this patient, is expected or typical of rabies. Non-canine transmission. So while dogs are our principal reservoirs, as mentioned by the study, with 91.2% of our cases being from dogs, it would be unfair to our communities to disregard the other hosts of rabies, including domestic cats. In the US and in Australia right now, their problem is with bats. They have successfully been able to wipe out rabies from dogs, and they're now battling with rabies from bats. WHO recommends women intake. I don't know if there's something So WHO's recommendation, according to the 2024 WHO rabies fact sheet, is immediate wound washing plus the rabies immunoglobulin plus a 4-dose vaccine. Here in Ghana, we're still using the 5-dose vaccine. We're yet to adopt the 4-dose vaccine. PEP is required for any mammalian bite in an endemic area. So anybody that comes to you with a monkey bite, a cat bite, once it's a mammal that bits them and they live in a rabies endemic area like Ghana, you should consider giving them post-exposure prophylaxis, because your missed post-exposure prophylaxis would lead to preventable fatality. The rabies immunoglobulin and then the vaccines are readily available currently in our country. They are a bit on the pricey side, which might be a limitation to accessibility and availability for our clients, because for an average 70 kg man, you need about 2,000 cedis to fully give them the post-exposure prophylaxis. A vial of the rabies immunoglobulin goes for 256 cedis, and the vial is 300 international units. You need 20 international units per kilo for the rabies immunoglobulin. So if you have an average 70 kg man, you're going to need about 5 vials of that, which would be about 1,280 cedis, which is not cheap. The vaccine currently sells for about 700 to 800 cedis, depending on which pharmacy you're buying it from, for all the 5 doses. So that is one of the limitations that we currently are experiencing with post-exposure prophylaxis for rabies in Ghana. In conclusion, you need to be aware that all mammalian bites must be treated as a rabies risk. We need stronger clinician education so that this does not happen again. We need to ensure that the vaccines are constantly available, and maybe advocate for a reduction in the prices, or if we could, there's a way we could partner with international organizations to be able to give them out for free even, that would be amazing. And then to improve public awareness so that when people's pets hurt them or they bite them, they can present to a facility for immediate care. These are our references. Thank you very much.
All right, so thank you very much, Dr. Aida, for keeping to the time and then bringing this very sensitive topic to us. So one thing we've learned from here is that rabies has no cure, so prevent it from happening. If you can't prevent the dog or the host animal from biting you, then try and get the treatment early. Just to add to this, we know for the immunoglobulin, you have to buy it. But I don't know how, in Kolebu, we are able to get the snake antivenom. We are able to get the rabies vaccine for free. And there was a time a colleague from WA wanted some of the antivenom because, you know, they have a lot of snake bites. And when I got to our chief pharmacist, what he said was that they could get them from the central stores. So instead of he giving it to them, he rather asked that their storekeeper should request. Somebody too from Odan, really down, we got some gift to a bus and then he went and gave to them. So please, let's insist that our chief pharmacist check from central stores at ministries. From ministries, they should just ask and they will get it so that we prevent deaths. Thank you all very much. And then we have 2 minutes for, all right, thank you.
So when she came in, because she was altered and then she had the intermittent agitation, a head CT was done, which was clean. There was nothing on the head CT. The biggest challenge to her management was keeping her blood pressures under control and making her comfortable because she was very agitated. And you know, in the ED, there's a lot of noise. Some monitors are going off, there's lights on, you can't turn off the lights because she's not the only patient in the ED. And unfortunately, in the UGMC ED, we could not isolate her at the time that she came. So that was our challenge with managing her.
I'm happy Dr. Owu is here. Critical care, UGMC. Why don't you have isolation? Are you saying you don't have isolation ward in your facility?
That's not what I'm saying. I'm saying in the ED, at the time she came in, we were unable to isolate her. So
you let the patient in the light, and the light killed the patient. Is that what you are telling me? You should create one. You should create. If you don't have, you should create it. It's a requirement to have an isolation ward at the ED. Is that not so? There is an isolation ward. So you can't put off the light there.
No, at the time that she was there.
Okay, you don't worry. I'll meet you outside.
Yes, please.
Because this is quality of care.
Yes, please.
You must get it because it's something that's common. That's why I'm just putting. Many a time we have everything at the ED, but some of this infrastructure, isolation area, it's not available here. Everybody is left in an uncomfortable place. I think we must, in some certain department or units in our department is critical. And the availability of rabies, you say you should call ministry when we have rabies. They should be available, closely available. So I think what we have not pushed for is that we have not actually asked whether they are even available or not. We always request when they are in need, emergency. And they will tell us, these ones, we don't store them easily here in the pharmacy. So if we have our knowledge that we are having cases, it will be stocked closer to your point of use. So it is good that emergency department heads must be talking to pharmacists. It shouldn't be in Accra. By the time you come back, the person has already popped off. But it's about communication, letting them know what needs to be stocked. And because some of these are public health medications, they are free. They are vaccines for public health use. But because difficulty in storage, they don't just give them anyhow, unless it's by special report. We are having snake bites. Voltarigin, let's send them a stock closer to them, then they can use it. So I think what you said is partly true, that you have to communicate for our pharmacies to stock them. When we are having cases, 1 or 2, and we are following up, it's an alert. And once the public health team gets to know, they will also assist. Thank you.
Thank you very much. Okay, so while the mic gets to her, my concern was that you said the BP control was a problem because the patient was agitated.
No, the agitation is a separate problem and the BP control is a separate problem.
Okay, but okay, why were you not able to control the BPs?
She was not responding, like her BPs were not responding to any medication.
Yes, because one of the things for this patient is that we need to sedate them. I mean, we must keep them just calm. Give them supportive care. At that point, there's not much we could do. Instead of allowing them to be struggling. Even if we don't have an isolation area in the ED, we should just find a place that is calm without much noise. And the patient stayed with you for 27 hours. That means more than a day. So it's not possible to say that within UGMC there was no room to keep that patient. And one of the things I observed is that when it happens that there's no one to care for them, that there should be someone who wear PPE and then give them, care with dignity. Okay? That's what we are trying to move to so that things will be fine with us in the emergency. Thank you.
Okay. Thanks for the lovely presentation. I want to ask if, per your research, any attempts been done, try the Milwaukee protocol? I realize that most of the rabies and the person is exhibiting fully, we tend to leave the person to manage. We are going to symptomatically manage the patient. But have you ever tried any other protocol, like the Milwaukee protocol, for instance? Sedate the person and bombard the person with antibiotics, antiretrovirals, antiviral medications, and see if the person responds. But it looks like most of the time, we leave the patient to just peacefully transition. But I think as system, you are supposed to try to see. After all, the person is going anyway. What prevents us from trying something so that we also develop something to help? Thank you.
All right, so Dr. Ida, you are discharged. You can go, and then the next person will be preparing. So let's just be sure of one thing. There is no cure for rabies. That's why we have to do the prevention. One, if we can eliminate rabies completely, that's it. And then the animals, when you want to keep a pet, try to see the veterinary so that one thing is that the pet culture is not that much in our part of the world. We keep them, and then we don't know what goes into it. So we should always ask advice from the veterinary. They will tell us there is vaccination for them. But we have the stray ones moving around. If anyone should have just a scratch even, just go to the hospital for the treatment. In terms of the protocol for management of exposure to dog bites, it exists already. Even if you go to Ghana Health Service protocol for managing dog bites, you just Google it, it will be there, and you see. So it's the supportive care mostly if the symptoms have shown already. Okay. So
also, to just add on to what Dr. Bulije said, the Milwaukee protocol has been labeled as controversial and discredited. So we will not be using it in our setting. Thank you.
Yes. Even though it's a presentation by education, we manage a patient who has rabies and he survived. They say it's not rabies. This was 2018. They told us it is not rabies. If it's rabies, you will die. So I'm happy somebody is challenging. Can it be a paper to show that confirmed rabies survive? Because sometimes, many times, COVID came. People were dying because we were afraid to manage them. Not that because we couldn't manage. Because COVID has no cure. This is a man living a testimony. So when COVID came, when you have COVID, and especially a severe one, and then all said, let's do something. We can't allow them to die. And now you have a protocol for managing severe and critical COVID cases. So maybe it's a challenge. Let's pick up those who are researchers. Because when we had it in 2018 and it survived, I see Ruben Queen, my own boss, public health, he said, for this one, it wasn't rabies. So if you rabies, you will die. But the good thing is that there are a lot of rabies campaign going on. We had support for vaccination. Public Health did some work now on rabies protocol. And so there are protocols That's been approved in Ghana now for use in managing people suspected to be having rabies. And then when it's confirming. But one good thing that we are doing with the animal health is that once a rabies is confirmed, the source must be found. And then they do autopsy to find out the cat or the dog. They do a lot of neuro autopsy to confirm, because now the world is growing and people are having the capacity to do that. Because if you don't do that, you always think that people have dysphagia and fear for water, rabies, therefore abandon, wait and die. And we must move on. I'm sure that we should be able to protect ourselves to manage those cases under critical care. And let's see what will happen. Before you know, they may survive. Thank you very much. So I'm challenging Dr. O.
All right, so just what I would say is an understanding of the pathophysiology, and Dr. Masley went through that pathophysiology, that this is a neurological injury. Having said that, we also are aware that there are variants to almost every communicable disease. Does it mean that every rabies case has died? The answer is no. There are actually documented cases of symptomatic rabies that did survive. They are very rare, extremely rare. The question is, those people who survive, how did we study them? There are antiviral, anti-sera that are used today because it was extracted from specific survivors of diseases that were known as non-survivable, because those people developed an abnormal level of antibody that others were not developing, and they were used to develop cure. So it is rare because the nerves had, in most cases, by the time they are presenting, had significant damage. But then the question you ask yourself is that the children and the husband who were also bitten by the same cat, if they were bitten 2 months ago or 1 month ago, and we are now giving them post-exposure prophylaxis, what does that mean? If they survive, at what point do we say that exposure to rabies becomes unsurvivable? Because that is the assumption of this presentation, that those 3 children and the husband did have exposure to rabies. And from your presentation, we didn't hear that they eventually got rabies. So it's either that the period of incubation or period of damage has a critical point beyond which it may become unsurvivable. And sometimes it's also actually understanding that critical point may actually help in developing how we manage this patient. So yes, it was a good question you asked, and it should challenge us to looking at some of those. Thank you.
Okay, so more topics are coming out for research. Let's try and pick them. All right, so our next speaker is Dr. Anita Esenam Agbeko. So really, I had never met her before, and when I was preparing my dissertation, there was a day, I have a big brother, Jonathan. So I was in Kumasi to discuss my work with him, and he said, oh, per the college guidelines, so let's call Dr. Esenam. So really, she helped me online, on phone. She didn't know that I was the one she was helping. But unfortunately enough, I don't have her bio to introduce her well, but I know that she's a vascular surgeon and a general surgeon. They are very scarce to find. Their procedures are very, very expensive. Yes. And she's a research person as well. So we welcome her to talk to us about... so it started from the emergency, but there's no money in emergency. And, you know, I was somewhere with someone, and there was a surgeon who was a female. And when he came, he said, this nurse should excuse her so that he will talk to us. And so everybody has a surgeon man. We say, oh, but normally women don't do surgery. But we have a woman surgeon. And she's coming to talk to us about palliative and end-of-life care, communication in the emergency department of Konfanochi Teaching Hospital, a mixed method study. So, Dr. Isenam, you're welcome.
Yes, he's very biased towards. Anyway, good evening, everybody. And yes, my topic has nothing to do with general surgery or vascular surgery, but I'm also a palliative care practitioner and a palliative care researcher. And that drives a lot of what I do. And I'm particularly interested in palliative and end-of-life care in acute settings, and hence this. Disclosure, this study was funded by the Royal College of Emergency Medicine LMIC Research Grant Fund. I was very glad about the presentation just preceding mine about a patient for whom there was nothing, should I say, curative-wise to be done besides making her comfortable till she died. And in the emergency setting, besides severe trauma, cancer with advancing age, people come through our doors all the time for whom there is no cure. And we must admit that as mortal human beings, that time has come for them to transition to another life. Unfortunately, palliative and end-of-life care discussions tend a lot of the time to lean towards cancer and now, other chronic or end-organ failure conditions. But hardly do we talk about them in the ED because we are very focused on ACLS, BLS, ATLS, and the patient must necessarily survive, even if what we are doing does not contribute to their quality of life. And hence, this study initially just looking at how we even conduct such difficult conversations in the ED. It was a mixed method, sequential, quantitative, then qualitative. And we used 2 survey tools to assess how people are comfortable with communication. And then there was a qualitative interview afterwards. We had 75 participants. You would see that, our distribution was more nurses than doctors, and we actually did this selection based on the proportion of staff in the ED. There were more nurses than there were doctors. Most of them were between the ages of 35 and 40. Just about a quarter of them had ever had any kind of palliative care exposure or training, and many had worked between 6 to 3 months in the emergency department. So the questions with the first survey tool, which was the self-efficacy in palliative care communication, using the communication subscale of that, looked at questions like if you've had discussions with people's likely cause of life-limiting illness. And these were questions with patients. If you had discussed general issues related to death and dying, concerns about death and dying, responding to their questions, specifically, how long have I got to live? And then if the patient asked, would you be suffering? And they were to score that on a scale of 0 to 7, where 7 was to mean that they could certainly do that, and 0 was not at all. And for this and other subsequent graphs that I'm going to show, you'd realize, well, most people are somewhere in between there. They can do it. They wouldn't call themselves experts at it, but they have some degree of confidence between, should I say, moderate, a bit low or high to be able to conduct these. And even if they were to have these discussions with families, again, the distribution across the scores were about the same. Then there was this other questionnaire, the comfort with communication in palliative care and end of life. That also looked at how do you find discussions with patients just after they've received bad news, spiritual and religious concerns. How comfortable are you, to just silently listen to patients talk about their feelings, discuss end-of-life decisions, physical symptoms, psychosocial symptoms, and talking to them without using jargons. And specifically, you'd realize for the things that, should I say, fall within what we would usually do, we assess physical symptoms, we'll take a social history, and we know how to talk to patients in lay language. So those bars towards the not difficult would probably have bigger peaks. And we're probably more comfortable just listening than offering hope or information that we didn't have. And it was the same when, clinicians were talking to families. The previous graph was about patients. This is if they were talking to families. Again, the same kind of trend with these things that we would usually do, but not with issues like when they've just received bad news. And interestingly, when it came to if we're talking to our own colleagues, most of us did not find that difficult, because for each, in fact, it's very easy for us to tag, with the EMFA. There's one of our, ED physicians in CAS, and sometimes when I'm doing ward rounds, she would say, as for this case, I'm not going to badge you about it because we all know where it's getting to. But we are more comfortable discussing terminal illness about our patients amongst ourselves. And for what the participants found most difficult to discuss, end-of-life care, followed by all the others. So, yes, you get a sense of generally, people do not do they do it well or not, and therefore the qualitative interviews that we had, which was with 10 clinicians, 5 nurses, 5 doctors. And the issues that came out really, which explained, that variability of, sometimes you probably feel a bit more confident doing it than not, were things about the ED space, that the pressure in that space, the time it takes for you to finish seeing one patient, move on to the other, there are people waiting. It's not a time to, sit with somebody on a chair and, put your hand around their neck or wait for them to cry for 30 minutes before you moved on to your next patient. And then people tended to draw on their religious and spiritual beliefs to be able to probably go ahead and conduct any kind of communication with these patients. Then there were those who were still, figuring out how to go about it, because you can just never be ready enough or prepared enough to tell someone that what they are going through and the phase of their life in which they are, they probably have, who knows, a few hours or a few days, or even if it's a few months, what they have is going to eventually take them out of this world. Plus, then there were those who would defer the communication, either to a senior or to a junior person, or if they've just had enough for that week and bereavement or something came up, they would probably just walk out and let somebody else do it because they couldn't take it. Then the impact on clinicians. There was a lot of admission about the emotional toll. I found, in fact, this very touching, that this was this: you put yourself in a patient's shoes, you think death is closer. When I'm coming to work every morning, I tell my children I might not return. Because this was somebody who had experienced a lot of, even people go out, they get car crashes, and then they come to the ED and they don't go back to their families. And at a point, you always felt that one day this could be me, that I could also actually just move out of home, be involved in an accident and not return. And people were getting to the state of avoidance. You just don't want to do that again. And I think that this was, should I say, the biggest part about this work for me, that we give all of ourselves to take care of our patients, but we are also suffering within. People carry these emotions with themselves. There are, I couldn't put every quote here. There are people who had lost families in the ED, and now every sort of similar situation evokes an emotion with them, and how do you deal with that? How do we cope with that? The stress about end-of-life care discussions in the ED is well known. I think it's probably not so well documented in our settings. I found this, there's a work by Bayo et al. That was done in Agogo Presbyterian Hospital, and all these things about there's no time, we cannot support, that people experience grief, and it's all buried in them is there. But there's opportunity for help through training, and actually through probably even deliberately integrating palliative care teams and palliative care services in the emergency department so that they support our emergency physicians. Because much as we have to save lives, we must admit that there are some too that we cannot do anything about. But we also have to preserve ourselves and be alive for the next patient to come through. And it's the hope that moving on from this would make more steps with regards to, how this project started, to probably put more palliative care, end-of-life care services within our emergency department. Thank you very much for your attention.
All right, so thank you very much. Confanoche is very lucky. You have a palliative care colleague in the emergency with you doing rounds. Yeah, Rich, hey, in my emergency, someone will come and write for palliative review. That's the end of it. It's your own business for you to go and look for someone to come and do the work for you. So you have a vascular surgeon, a palliative care expert, and all that in the emergency. That is great. Please, your contributions and questions. 2 minutes.
So one of the things so when we introduced our family counseling, palliative was part of it. And one of the things that people feared was the fact that you may say person is going and the person doesn't go. And I felt that it was more of like an up in your CV. Because if you tell somebody the person will go and the person doesn't go, that means you've done much more than was expected. So I don't know if there's something you can say to help relieve that fear. As in, I'm telling the person will die. Person eventually leaves the hospital. So they think... Yeah.
All right, so it's important to realize that acute care physicians and practitioners, nurses, and then EMTs, that every one of us work within a range of limitation, knowledge, competency, and experience. None of us know for sure which patient will survive. We may be able to tell that the likelihood, or we can prognosticate. Prognostication is not an absolute science. And if we don't understand this as acute care people, we begin to think we are gods. And that is when we are disappointed. When patients we have said will survive, die, and also disappointed when patient we say, oh, this one there, he will die, survives. And none of us, we've seen patients who literature says less than 5%, and they are still with us today. Some of the people who looked after them have died ahead of them. Yeah. So it is a training. Yeah. I remember when part of my training outside this country, when I said to people, one of the biggest thing I learned is how to talk about difficult conversation. And I remember my colleagues in Edinburgh at some point in time thought that this guy must be a sadist. Why? Everybody doesn't want to sit when we are discussing bad news, because at that point we're even asking for organs. Yeah. And then this only black boy in the whole department, says that even if he's at home and there is a difficult discussion, give him a call, he will come. He wants to listen. We introduced this in ICU in Kolebu when we opened, and that basically led to how we talk to people. There are a lot of people who are anxious, including the patient. A good number of our patients die from their anxiety because they are so scared that they don't work with you. But then when you start communicating with them, we always say about 50% of the work is the patient themselves, not our science. So then, how do you talk to them? So, Nanefua, the important thing is, it doesn't matter how severely, I never say to a patient, relative or a patient, this will definitely die. You can say to them that the likelihood of a good outcome is poor. But as long as you continue to give acute care without basically withdrawing care, that is actually you admitting that there's a chance. And that you need to make clear. we are usually afraid that if we say that and they don't survive, then the family thinks that so we make promises and then we run away from justification of that promises. Now, the other thing I wanted to touch on is this care for the caregiver. And I love what you people are doing with your lesson. We basically introduced the same in ICU, group counseling for the health workers, proper debriefing. People are still blaming themselves for mortalities that they could do nothing about. And it's not because they thought they didn't manage the patient well, because they feel guilty that the patient died. And we had the opportunity of Professor Mate Kole, the clinical psychologist, talking to him, and then he helped us develop that. And then we had a clinical psychologist in the ICU who worked with us permanently for a long time and debriefs with us and then works on stuff. Gradually, it becomes as if the norm and then it disappears. Yeah. And I think in the emergency room, it's important. We cannot be too busy. Oh, another patient is coming, another patient is coming. When you drop, we'll still be busy. So even the short 5 minutes to debrief, to say to people, thank you for what you've been able to do, maybe the only time the person hears it. Yeah. In COVID, that was actually a psychosocial support director, was among our biggest success. It became so much part of what we did, not only for patients, but for ourselves. And that's how we could continue to go after 6 months, because it was sapping everything out of us. So we should remember that we should manage the caregiver.
What were they doing that they are finished right now? What were they doing? They didn't ask any questions.
Oh, yeah, 1 year. Yes. Okay, I think our colleagues from the other place is joining us for. Oh, no, the question is coming from those who were here. Please.
Thank you very much. Mine is not so much a question as a comment. I was very touched when you said EMs need help, because it's true, we do. As somebody who struggled with end-of-life communication at the beginning of my training, I can relate to a lot of the comments that you projected. But my comment is to the next phase of this, because based on this recommendation, training programs will come out. And not the psychosocial support for each other, but when we are training to communicate at end of life, I am suggesting that we don't adopt wholesale protocols that already exist. Because when it comes to death, the sociocultural differences are very important and they are very vast. So my recommendation is that as a follow-up to this work, we develop context-appropriate training protocols rather than wholesale adopting ones that exist from other cultures because of this difference. Thank you.
Thank you very much.
Second
one. So, Dr. Sinam, what I wanted to ask was the challenge that most of us face with communicating end-of-life care, especially when you know that the family has expressed resource constraints, is that you are afraid that when you let them know that prognosis is poor, they might withdraw financial support, because if the person is going to die, why then do we continue? So in situations like that, that usually is one of the challenges that we especially face. So we wanted to know how to navigate. Like, what do you say? How do you go about it?
You know, my answer to this is these kind of questions. There's always no one solution that fits all. It all comes down to sitting and having an open communication. Because there's an arm of that argument that would say, look, say they're a poor family or there are kids that need to go to school and everything. And there are families that have been driven into abject poverty after one person getting ill in their family. And their patients have had communication with with regards to cancer diagnosis, for example, and they make certain treatment choices because they want to be able to make some investment for their wife to be able to take care of the children when they are gone and all that. Different people take it different ways, and it's always about an open communication. And when you feel you do not have the capacity to do that, call for the appropriate help to be able to navigate those conversations for you. But there's no one single answer that fits everything. Thank you.
Dr. Esinam, thank you very much. Okay. All right, so let's always use the experts to solve problems. When it comes to, let's say Dr. Odro said something. In tree, my tree is not good, so I won't say it. He said, it's the most difficult work that you give out for people to do for you. As emergency workers, EMTs, the nurses, the doctors, everybody in the hospital, we know how to take care of the patient. When it comes to some other parts that we are not very comfortable with, let's use the experts. Okay, thank you very much. Okay. Dr. Who wants to tell us something before?
No, just an information. We talked about the rabies earlier on, and I will share this with the organizers to share. So among those who were listening online was one of our earlier presenters, Dr. Conrad Bacco. And he did send one of the studies that has been published about survivors. So I will share that. It's published in the Journal of Clinical Virology, and that looked at about 11 survival cases of rabies, including the particular case of the team that were reporting of a 4-year-old boy who was bitten, and then he actually had post-exposure prophylaxis, but still developed rabies. And 4.5 years down the line, that was when they were actually investigating and had PCR variants. Yeah. So we will share that.
All right, so thank you very much. We've been talking about basic emergency care, and I think the director from Ghana Health Service will be happy with that because, as he announced, they have the primary emergency care for Ghana Health Service. National Ambulance, they also have the community emergency care that is ongoing. And if there is nothing at all we take away from here, we should all know that the basic emergency care is for all of us. You'll be surprised that a professor can set a line and a medical student will rather set it. A medical officer will set it. This tells us that even when we go high, we should always remember the basic. All right. So, all that this is telling us is that for the basic emergency care, even when you are growing older, you should always remember that there's something called the basic. We should always remember it. Other than that, somebody will come with a very simple thing and will be thinking of huge abstract things. So for that reason, Dr. Kwame Akresi is coming to talk to us about longitudinal knowledge retention after WHO Basic Emergency Care course. Anybody who has not taken that course yet should try and have it done. It's very important. So Dr. Akresi, we are in your hands.
Thank you very much, Dr. Bule. Although those that do that, they haven't read The Art of War. You never outshine the master. I don't know whether I'm lucky or unlucky to be the one presenting when all the groups are here, but I'll do my best to maintain your attention. I always say that the worst time to present is right before lunch. The second worst time to present is right after lunch. And the third worst time is the last one. So I'm unlucky with the third one, but I'll try and keep your attention. I'm presenting, this research is a triple phase, basically, and I'm presenting the first part of it, which is the raw data analysis. We did a WHO basic emergency care course for a group of healthcare workers, and we did a study on the longitudinal knowledge retention after that, and that's the data I'm presenting to you today. So basically, the WHO basic emergency care course, all throughout the conference, we were talking about strengthening the front line, what we can do, local solutions for global impact. The WHO Basic Emergency Care Course is one such tool that is essential for strengthening the frontline emergency care in low-resource settings. It focuses on practical skills and knowledge for healthcare providers in these settings. This presentation outlines a study conducted on the pre, post, and then 1 year post workshop retention of knowledge. The first contact healthcare workers trained to provide timely and quality care. These are the cornerstones of every integrated health service. And I think over the past 2 days, this has been made very clear to us. However, where we find ourselves, the overwhelming majority of what we call first contact healthcare workers are found in resource-limited areas. This applies locally as well as in the sub-Saharan region. Most of us are working with limited equipment, high patient volumes, and a relatively untrained workforce. This makes a structured and easily assimilated emergency care training very essential. And basic emergency care course is one of these things. To address this need, in 2018, WHO partnered with the International Community of the Red Cross and International Federation of Emergency Medicine and developed this workshop or this program called the Basic Emergency Care Course. And this is my favorite sentence in the whole presentation. It's a 5-day systematically designed, context-appropriate training program. That's all you basically need to know about the Basic Emergency Care Course. It's a 5-day systematically designed, context-appropriate training program. It aims to equip multidisciplinary providers with the skills to rapidly assess, triage, and stabilize acutely ill or injured patients. The curriculum emphasizes these 4 items. One is the ABCD approach to every emergency. That's sort of like our mantra, that's our anthem as emergency physicians. 2 is low-cost and adaptable techniques suited to a resource-limited environment. And I prefer the term resource-limited to low-resource environments. Team-based learning, that's another aspect of it, which is more highlighted in the second part, which is a qualitative analysis of some of the participants who were in the workshop. And it comes to bear that they really valued the team-based approach. This ensures applicability across all cadres of staff, including nurses, PAs, doctors, midwife, etc. And then, of course, a practical hands-on instruction supported by case-based scenario, which evidence has shown is the best way to learn. While BEC training has been proven to be useful, and so it's been adopted across Africa, there's limited knowledge on the retention that remains a while after the BEC, because what we see is there's a huge drive in most countries for BEC to be developed, and it's all based on the fact that post-BEC skills and knowledge have actually been gained. But down the line, you see that BEC begins to fizzle out in the country, whether it's due to resources or due to management, I don't know. But there exists a substantial gap in the knowledge retention that remains after a BEC. So why is this important to know? Because if we know this, it can help guide policy on refresher training frequencies, and then supporting integration of BEC into national emergency care strengthening initiatives, which we are here to deliberate on, and then ensuring frontline providers maintain competence over time. Because what happens is that if you're not around a system that is a formalized emergency medicine training center, once you are trained and you go back to baseline, you are basically going back to square one, and the effect is cost 90. So this study examines the immediate learning gains and then the 1 year knowledge retention among Ghanaian healthcare workers who completed a basic emergency care course. It was a quasi-experimental pre- and post-intervention study with a 1 year follow-up. We had about 54 clinical staff made up of nurses, PAs, doctors, and midwives. The intervention was the aforementioned WHO BEC course. How did we do this? We conducted a baseline assessment before the workshop to evaluate initial knowledge skills. Then we delivered the training. Once we delivered the training, we did an immediate post-training assessment. 12 months later, we conducted a similar assessment to assess the retention of the knowledge. And then we've analyzed the data, and we followed it up with interviews, key participant in interviews. That will be the second part of the research. Of our participants, 52% were female, 48% was male, which reflects sort of the distribution in the general population. We had 33% being doctors, we had 46% being nurses, and yesterday we heard that if you can't train doctors, train nurses. And for every management workshop, every leadership workshop I've been to, when it comes to establishing a unit, strengthening a unit, it always starts with nurses. So I'm very glad that the largest number of participants in this basic emergency care course were nurses. We even had 2% EM specialists joining us, EM residents as well, about 11%, EMTs and physician assistants all joined the workshop. When it comes to the level of experience, the years of experience, it was also very varied. So we had ranging from less than 3 years to 9 to 12 years. For some reason, 46% did not indicate how many years they've served. Whether this slide explains it or not, I don't know, but we are here to establish it. Okay, some of you caught that joke. And then we did we did a comparative study of the baseline assessment. So about 75, the mean score on the pre-test was about 75%, which was surprisingly good. But because this was the first workshop in the series that is planned, and it was initiated by people that work in the emergency department, it stands to reason that there is some level of baseline emergency care knowledge among the participants because of where it was initiated. However, we saw a very significant increase in knowledge and skill post-workshop to about 92%, where the mean score for the post-test was about 92%. 12 months later, certainly, there was a dip. But the dip was only to about 87%. Now, the mean score after 12 months, about 87%. What does this tell us? Comparison with immediate post-test, small but significant decline. Comparison with the baseline before the workshop, again, knowledge remains significantly higher. So these are two aspects to the pie that we need to use for our recommendations. So therefore, what are we saying? To sustain peak competence, it is recommended to incorporate a periodic refresher training sessions, ideally on at least a biannual basis. It is quite clear that the effect of the basic emergency care course is a very positive one. However, 12 months after experiencing it, the retention dips a little bit. It is still important, and so if you can only do it once, by all means, do it once. But if your goal is to sustain peak competence, then you need to refresh, and the ideal recommendation is at least twice a year. It delivers a substantial statistical, so our assessment indicated what I just said, and the effectiveness highlights the importance of a structured and context-appropriate emergency care training in low-resource settings. The other thing about the retention that comes to light is that because the dip is so little, it stands to reason that the training was appropriate and context-specific because they left the training session at the higher facility, went back to the lower facility and still retained a lot of the knowledge. And so this context-specific training was very useful. However, regular refresher programs are key to long-term success and capacity building in emergency healthcare systems. I did not mention the authors because we're not done with the work. This is just the first part, but we would like to give acknowledgements to Royal College of Emergency Medicine, EMSOG, WHO, our basic emergency care course, our master trainers, our trainers, of course, members of CATH Emergency Department, and then members of the University Health Services, KNUST, who participated in this work. Thank you very much.
All right, Dr. Chrissy, thank you very much. Our timekeeper was a bit biased because he's back. Yes. Our master trainer one was a bit biased, but we will not talk much. All right, so thank you very much for throwing light on the basic emergency care, how we've been able to retain the knowledge or not, and it tells us that we need to do regular training and all that. We thank you all very much, and then we invite contributions and then questions. We'll also be biased, about 3 of them, instead of 2. Thank you.
Okay. You said doing the training biannually would help with knowledge retention. How did you come up with that? How did you come to that conclusion?
So that recommendation was a bit premature. I mean, it's clear that after 1 year, there is a drop. So it should be done more frequently than annually. That one is evident in the statistics. But in the key participant interviews that we did, we asked for recommendation from the participants who saw a positive impact on their work. And that was sort of the general consensus that came out from that part. So that's like the second part that informed some of the recommendations.
Thank you. All right, thank you very much. I think when I came for this meeting, you have been hearing trainings. I think some of us, we are shortchanged because where we are, I think most of the trainings are done at the pre-side, the regional, and leaving the district hospitals. I think we are shortchanged. So I don't know when this back came. But
right.
Yes, so at least now that you have a second back ongoing, I don't know when you're going to start, but just pleading if you can come there.
If I can find out, what facility are you from?
In King Kenso Government Hospital.
Okay.
That's
so
the premier
maybe
district
that
hospital
discussion is probably beyond this presentation, but you're 100% right. And I mean, we are lucky because of where we are situated and our proximity to some of these courses. We did extend. Some of the nurses involved are from different facilities. We had Kumasi South, we had Agogo Presbyterian, we had Suntreso. So we do invite people, but you are right, proximity is an issue. And I think earlier I was talking to Dr. Uwu about this, that the fastest way to get this to spread is to train trainers who train trainers, who train trainers, who train trainers. And it has been discussed. So Beck was involved in 2018. It got to our 10 in 2024. Calm down. Your 10 will come. Can't worry. Your 10 will come, I promise.
Yes, I think I was waiting for a business meeting tomorrow. Deadly, my flight is taken at 8 a.m. Try to change. They are not changing. Beck started in 2018, and you are in 2025. Can we have data of how many people who have gone through Beck? Because I have 144,000 staff in Ghana Health Service. And then...
But this one, I'll have to ask my master trainers
to
help me with this data.
I want to be very sure because... no, I said I have 144,000 and I want to train... You have me, let me finish my question. Saying your 600 will not do one thing for 144,000 people. We need to train. That's what we are discussing here. How can we change the model? Because to me, cost is a factor. My brother, I think, can also want to be trained. I cannot pay $80 or $50 for him to come and train. So we need to have a proactive. Tomorrow, I think that's one of the things that I'm taking. We need to train Ghanaians. That showed about 23% have gone through emergency training for the past 2 years. It's hardcore data. It's not a story. How do we... The same way we cannot wait for 50 years to train 50 or 500 emergencies. We need to design a way, a model. And so I think as I'm leaving, I'm selling it up. We need to come out strategically because we need an answer tomorrow to communicate. As I communicate to go out there, there must be a strategy, there must be cooperation, there must be partnership, there must be funding. And we must have people who are also willing not to stay in Kumasi alone to train, but to move to the villages to go and train people. These are the ways to, because if you want to catch up and train 2, even 5,000 in 1 year, we have to change the approach. Until we change the approach and make things affordable, adopt the Beck to be Ghana. This is a local solution for international solutions. So we have to have we cannot wait for Afro to determine the cost of Beck training for us in Ghana. If you want to wait, we'll wait. But there must be a decision to move. That cost should not be a barrier for capacity building. And access should not be a barrier. Everybody, wherever you are, you should be able to have access to go through Beck and have the competency. So that is my solutions I want. If I get that solution, I can talk to the minister tomorrow. Thank you very much.
Okay, I think our recent master trainer would want to see, a freshest master trainer would want to answer this one.
Don't worry, I'll train you to become a master trainer. It's my brother, you people. And yeah, this is a very important thing. It's not only for the health system, it's also for your families. You may think that you're sitting in UGMC or Kamfanoche and then you are providing the best of care. You don't know where your own family members would seek for care. And we've all seen that in our care. Half of the time my family had required care. Did I say half? I think there's only been one time that my family had required care in UGMC. So other people end up looking after them. So we have to think about that. The discussion Director ICD mentioned is a discussion we have started, not even during lunch with the President EMSOG and the Master Trainer 1. And it's a discussion that we commit to getting to the root of. We have to train. We have to make sure that people are prepared. There are other ways we can make this easier, and we've already started looking at some of those and then piloting them in a number of centers. The other thing I want to say is there is no point in finishing training medical school, nursing training college, now that we know we have some of these things, and then wait to become doctors and cry foul. So one of the discussions we're also generating is the medical schools and the nursing training colleges, because the students are there. So one of the things we are pushing for UGMS is going to be actually introducing some of this training in the final year coordinated course, which at the moment, sometimes they are wasting 6 weeks walking from one place to the other, doing nothing. And we started that discussion so that if we are able to push this into curriculum, then when they become doctors, nurses, and the allied health professionals, it becomes just update courses. Update courses can be done in a day, just like what is talking about. Refresher, you don't need to do a 5-day back refresher. If you are doing a 5-day back refresher, you are saying that the person's knowledge and competency has totally decayed. And that is not what your study showed. So I believe that as acute care people, let's commit to that discussion. We are fortunate to have one of our own actually leading the biggest group of health workers. We could have somebody who doesn't understand what we're talking about, and we now have to go and lobby him. We have one of our own. It is the time to make those changes now. So what we can say to you is that we're going to work on that and make sure that training gets to everyone, irrespective of where they are. On that note, I have a flight to catch.
All right, please, you can. We'll take over. Oh, I have it. Director, I heard you wanted the numbers. I'll give it to you. We have it. We actually spoke about it. And just, if you can spare me 30 seconds. Whatever director was saying, I buy into that, 100%. The only thing is that Afro doesn't necessarily determine how much BEC should cost. From Afro is free. So the local dynamics, I think we should take a look at it. Because whatever funding that becomes extravagant, I don't think if we take it to director, he will even consider it. And that is where I think EMSOG and director's office will come together. We'll find a very common ground for us all to have the widespread dissemination of BEC so that we can all be providers of BEC. So I'll get in touch, director, and then we will sort that one out. All right.
I'm asking him a question. So So when are we taking on the online and then the 2-day or 1.5 day?
So fortunately, there's a hybrid form of bake. I think it's only 2 of us. I think it's only 2 of us who are certified to do that training. And we're looking at expanding the number so that we can just train the rest of Ghana. So we'll come together and then we'll see. The hybrid course is quite cheap relatively because it's just basically a day, maximum a day and a half. So whichever option that we go, I think we will still be good and we will have the chance to learn from Beck. All right.
I also want to add that there is also the modular component. So even though previously we used to do 4 or 5 days, now you can actually spread it along. Some countries are adapting, putting it in the curriculum of even the medical school as well. So it is not only the 5-day course, but there's also a modular component. Currently, UGMC, they have a target of training all health workers at UGMC. They have trained 150 workers, and then they have their own trainers who have progressed and all that. So now they did it for 5 days. They did I think the normal training, but now they are going to progress to do the modular form of it. So they are probably going to be the first to start, and then we'll see how that can be propagated so that you didn't have to take one staff for 5 days off duty. So that's what the modular components would also give. So what they are planning to do is, if you are assigned to Mondays, every Monday you would come. They also come on Tuesday, so that you still have the staff, core staff within the facility working. So we'll see how that goes. All right, thank you very much.
All right, so thank you all very much for staying for this session. We are grateful for your contributions and then the knowledge they've shared with us. I mean, this is a knowledge sharing forum where everybody gives whatever experience they have. So we've all learned something from here, and we pray that as we go back to our facilities, we've not ended the program, it's up to tomorrow. We implement some of the things that we've learned from here. So thank you for now. For this session, the organizers will continue talking to us, please. So thank you very much.
So we are done with the abstract presentations. We go to the next item, which is women in emergency care. I'll hand over to our moderator, Dr. Nana Sewakwa. Thank you.
Okay, thank you all very much. There's been a slight change in plans. Please, how many of us are on the WhatsApp group for EMSOG? There's an EMSOG WhatsApp group. Please, how many of us are on it? Please, those of us who are not on it, please, why are you not on it? Okay, so it's a very simple solution. Please, as you are heading out, see members of the Secretariat and be added to the WhatsApp group. Thank you. The reason I bring that up is we have put together a social program. So please, yes, please. There's a social program that's going on this evening. It's a hangout at CEDA. The location is on the group, and if you ask at the EMSOG Secretariat desk, they'll direct you there as well. We have done a lot of knowledge sharing, a lot of information. We want to go and sit together, enjoy some good music, good atmosphere, and then if you want to eat or drink anything, you are welcome to do so at your own cost. While we have had a lot of dignitaries join us over the past few hours, and we have one more with us. We have with us the president of the Ghana College of Nurses and Midwives, who has been here. She's actually been here for the latter half of today, including the abstract presentations, in the person of Professor Baum. Please, shall we welcome her with a round of applause? So, yes, please. So for today, we are ending with a little teaser for tomorrow. We were supposed to have the women in leadership section, but it's being moved to tomorrow. But we know that you are hungry and you are desperate for more knowledge, more insights into what it means to be a woman in leadership. And so we want to give Professor Baum the chance to speak with us. So please let's welcome her with a round of applause.
Thank you very much for the opportunity. I'm speaking on behalf of Ghana College and then KNUST School of Nursing and Midwifery. I was very happy with the presentations and the interactions, and I had the director talking about training so many people. I take that on board and will take that message to the college so that would create opportunities of training more nurses, you know, bringing them on board, the issue of incorporating the BEC into the curriculum so that people will be trained much earlier. Thank you for the opportunity.
Thank you very much, Professor Baum. So please, our session for today is done. Thank you all for your attention. Thank you for staying from the very beginning to the very end. Tomorrow we start once again at 8:30. Today it didn't really work out because the majority of us were not here on time. So we hope that tomorrow, as it's a Saturday, there'll be less traffic in town, and so that doesn't impair on us too much. And tomorrow is the main agenda for tomorrow is the business meeting for EMSOG. As an association, we need to come together and deliberate and make decisions for where we are and where we are going. In light of that, we want to brand the association. So the business attire for tomorrow is the EMSOG t-shirts. If you do not have an EMSOG t-shirt, you do not have a problem. There's a desk outside where they are being sold. The colors are navy and white. Please pass by. It is 70 cedis per piece. We have sizes that should cover a wide range of people, but hopefully for tomorrow, we have some academic sessions, but our main focus is the business meeting. So please, let's all grab our t-shirts, and we are coming tomorrow at 8:30 a.m. From here, we are moving to Cedar. Cedar, yes, it says it's in Denyame, so you can either follow the location on the group or put it in Uber, Bolt, etc. Again, if you are not in the WhatsApp group, please, you are missing out. Please see the Secretariat team. They will take your number and find a way to get you into the group. Thank you all very much and have a good evening, and we will see you at Cedar.